Hello, everybody. I'm Carolyn Byrne. I'm the Governmental Affairs Director for Public Health, and we are offering you an update to the Back to School Toolkit today. Today is September 23rd, 2021. We are so delighted that we've been on this COVID adventure together for going on 19 months now, and we just wanted to provide you with some additional information. And we are delighted to have as our speakers today Dr. Karen Landers and Dr. Wes Stubblefield, who are both pediatricians as well as ADPH medical officers. So thank you so much for joining us, Dr. Landers and Dr. Stubblefield, and I'm going to turn it over to you.
Thank you, Carolyn. And talking about what we want to do as far as the update of the school toolkit, is we want to inform about a few changes that we have looked at here in the Alabama Department of Public Health and determined that these really could be helpful to our keeping kids safely in the classroom. So I'm going to talk about some general information and some definitions, and then Dr. Stubblefield, who has recently joined us from his private practice setting, will speak to the issue of school scenarios and how these can be applicable. So let's talk about this update. I want to first of all remind people what community transmission really means. Community transmission relates to how much COVID we really have going on, how many cases we have, how much positivity we have in terms of testing. And in order for us to make recommendations about what is going on in a local community or even in the state of Alabama, we have to weigh really several parameters, but a couple of options here that we want to see is really looking at what high, substantial, moderate, and low mean. Now, as you know, as of this moment, most of the state of Alabama is in the high level of transmission. Certainly, for us to feel comfortable with relaxation of mitigation, and again, we speak about mitigation in terms of our measures such as social distancing, hand washing, and mask. And again, in order for us to feel comfortable relaxing, we have to get much, much lower than high level, and really to the point of low before we feel that mitigation layers can be removed. Now, obviously, we want everyone 12 years of age and above to be vaccinated against COVID-19. And we know there's discussion for vaccine in the 5 to 11 age group. For now, our community transmission is high in Alabama, so we really should make the assumption that we have a lot of COVID and everyone has COVID and act accordingly. And that way we will keep our level of awareness where it needs to be to hopefully protect our families, ourselves, and our community and get this under control. Now, on our dashboard, we have levels of community transmission by indicators. And just for example, as I said, we're in the high level at the moment pretty much throughout the state. And that means really 100 or more cases per 100,000 persons and a percent positivity of greater than or equal to 10%. Over the last several days, we have been in the teens, up 15 or so percent positive with our test. Last week we were in the 20%. So we are going down a little bit, and we actually could talk about that later. But we're still nowhere near relaxation of mitigation. Now, obviously, again, to get to where I would like to see us, and that is in the low range, you have to remember that we have to get really down to less than 5% positivity and less than 10 cases per 100,000. So we have a way to go before we can move into, again, substantial, moderate, and then low. And it would be very unlikely for us to jump from high to low. I mean, that possibly could happen in a few situations, but I really don't see that. I think we will gradually go down. So again, while we have high community transmission, we need to use the maximum layering of the mitigation standards and get our vaccine rates as high as possible. Right now in the state of Alabama, we probably have about 50% of the population as of, again, today, that has received at least one dose, and we're a little over 40% fully vaccinated. That's not where we need to be. Now, let's move forward and talk about the review of definitions. What is isolation? And again, isolation is a term that we've talked about for this entire pandemic. It's actually not a new term, obviously, because there are isolation standards for other communicable diseases. And again, if we step back and look at this as overall infection control measures, all of the measures that we talk about are ways to reduce persons contracting disease. I mean, that is essentially what we're talking about, is infection control of this viral respiratory droplet disease and this now vaccine preventable disease. So isolation means keeping a person who is diagnosed with COVID, for example, away from other people so that other people will not contract this illness. Now again, if we're talking about adults, it's easier for adults to isolate than children because, again, adults can largely take care of themselves, but certainly we've had cases of COVID in a home situation that required another member of the family or a friend or someone in there to be taking care of a person depending on how ill they were. At this point in time, the isolation for COVID-19 is 10 days. It is 10 days from the positive test or the onset of symptoms. And this is something we really need to clarify because some persons can have COVID-19 and be asymptomatic. But once you have a positive test, or once you have onset of symptoms, you need to isolate for a full 10 days. And I remind people, 10 full days, so that means you can come out of isolation on day 11. Now, something that we want to clarify in addition is that persons cannot test out of isolation. And by that I mean once you're a case of COVID, and again, one of our nurses pointed this out to me, I thought very clearly just a moment ago when we were having a conversation, and that is to remind that when persons have a positive test, for example, if they're a COVID-19, they have a positive test, a lot has to do with the technique of that test. And for example, a test that is done on day 2 or 3 of the illness, again, the technique, the swab that is being done for that person, again, the amount of material that is collected on that swab, again, could be very significant in terms of the positivity of that test. But maybe a few days later, we've had people say, well, I don't really feel that badly. I'm going to go to a different entity and I'm going to be tested. And then if their test comes back negative, they assume, okay, I don't have COVID anymore. Well, that's not correct. Again, a lot can relate to the technique of that test, or even in this, particular situation, we're really looking at the genetic material of the virus, and we just may not pick that up on a second or third test. But again, once the person is positive, they need to be isolated, and people do not have to have a repeat test in order to be out of their isolation. They need to serve 10 days of isolation, and then they don't need a repeat test. They don't need a negative test to return to work, to return to school, or anything of that nature. Keep in mind, early on in COVID, we did some things differently than we do now. But again, no testing out of isolation, but at the same time, you don't need a negative test to complete your isolation. Let's talk about quarantine. And again, quarantine is not a word that I specifically like, because I think sometimes people look at that and they see that more as, an authoritarian way to look at something. But quarantine is really a measure to protect people, to protect other people that have been exposed. And again, this is the term that we use because it's probably the best description that we have of people staying at home and staying away from other people once they have been exposed to COVID, so that they can not spread their disease to other people. Now, why do we ask for quarantine? Why do we ask for people to stay at home once they have been exposed to COVID-19? Well, there's a very good reason for that, and that is that the incubation period for this particular virus can range between 2 and 14 days. Now, again, if we look at some of the scientific literature, what we have seen more recently is that probably about 95% of people will convert to a positive test within about 7 days after their exposure. But again, that still leaves about 5% out there. And so that is why last year CDC still allowed gave the preference for 14 days, but allowed a shorter quarantine to 10 days, because by the time you get to about 10 days after exposure, you're probably up to about 97% of people that will be picked up in terms of a positive test. But also some other options have been discussed. So again, 14 days remains optimal. 14 days of self-monitoring, continuing to wear your mask, wash your hands, and stay 6 feet away from people. Again, 14 days is optimal. But we understand that there are physical barriers and mental burdens to the 14-day quarantine. So in Alabama, we have allowed the 10-day home quarantine. We are going to be discussing today our 7-day option, which the 7-day option is available, again, if the 14 days causes physical or mental burden and or economic hardship in the context of talking about children in school. We are going to continue to require the 10-day home quarantine other than children in school that are identified as close contacts. And again, we will discuss further how we are going to be implementing that 7-day option. Again, the 7-day option is allowed in the CDC literature, and states can determine what options are best for their states given their overall situation and their community transmission. What is exposure notification? Well, let's think about COVID-19 as another communicable disease. I think that because we have the volume of cases that we have, it has been a bit confusing, and sometimes people have wanted to separate COVID away and say, okay, well, this is totally different. Well, there are a lot of things about COVID that are different, but there are some things about COVID that are about the same as other communicable diseases, and that is that we have measures to reduce the transmission of this disease. We have measures to mitigate this disease. We have measures to vaccinate against this disease. But it is really our obligation as healthcare professionals, as well as in the school settings, to notify people when they've been exposed to a communicable disease. I mean, we would do this with measles, we would do this with tuberculosis, we would do this with pertussis. So why would we not do this with COVID? We're going to do exposure notification. Now, this really has to be done in the school setting because we, as the Alabama Department of Public Health, are not there in the classroom, so we really don't know who's exposed to whom. I mean, we really do not have that information. So again, the school has to do the exposure notification because they know where the students are. We don't. We are not able to call every case of COVID-19 in our current situation here in Alabama because we have over 3,000 to 5,000 cases a day right now. So again, we're not able to call every person. We're not able to investigate every case. And again, with the very high community transmission, that probably would not be feasible even if we had the massive staff that it would take to do that. So exposure notification, again, think of it as we would tell people if we had a case of another communicable disease in their classroom for which there was public health intervention. So we're letting the person or the caregiver know that someone has been exposed to an infectious disease and the person needs to follow the recommendations so that, again, they will not transmit this disease to other people. Now, what is contact tracing? And again, contact tracing is something that is on a different level from exposure notification because this is really a public health measure. It is an investigative process that is used by public health to not only look at the exposure pattern of a disease, but look at this in terms of tracking the entire process of who an individual might be exposed to, for what period of time they were exposed, other people that could be infected, other people that could be at risk to be infected. And we do contact tracing in context of other communicable diseases. But this is a far more extensive process than telling someone you have been a contact to a case of COVID, these are the guidelines that need to be followed. Quarantine in the classroom, I really think that CDC did a very good job in looking at literature on this, and specifically looking at some studies that were done here in the United States. And I like to point to what was done in North Carolina by Duke University and really compliment them on the way that they did a particular study of children in classrooms where there was consistent and correct use of well-fitted masks. And again, obviously, we want to make sure that children wear their mask, that the mask covers the nose and the mouth, and again, that they keep the mask on during the classroom, and have 3 feet or more of distance from the infected student. Again, if we have this particular scenario where kids are wearing masks, of course teachers should be wearing masks too, and the 3 feet of distance between the students, obviously to the extent possible, then really those kids that are more than 3 feet and consistently wearing their mask are really not contacts, and they can remain in the classroom. This applies only to students, and I know people are going to ask, well, why doesn't it apply to the teachers? Well, the study was done in the classroom setting related to the children in the classroom, and Dr. Stubblefield actually pointed out to me today, again, having recently been in the primary care setting, just how important it was to be able to monitor this in the classroom, and really that kids were able to be more consistently monitored because of their being there in the classroom than monitoring adults. So again, the reason for the 3 feet or more and the consistent and correct wearing of masks, allowing kids to remain in the classroom as opposed to having to home quarantine as we did last year, using the 6-foot rule. I mean, really this relates to some studies, as I said, that were done, again, specifically in children and in the classroom setting. Exceptions to quarantine. Again, no one wants to home quarantine. You know, I don't want to home quarantine. No one wants to do that because it's disruptive to your life. It's disruptive to your work setting. You know, parents have to rearrange their particular schedule. Someone has to be at home with the children. So no one wants to do this. But again, we need to protect other people, and we would want the same consideration for ourselves if we were exposed to COVID-19, again, by someone not following home quarantine. We would want people to be respectful of us as well. So again, what are the exceptions? Well, of course, the exceptions are if we have asymptomatic, and I stress asymptomatic, vaccinated contacts, again, asymptomatic and vaccinated, but they need to monitor very closely. And of course, we're assuming that mitigation is in place. You know, please wear your mask and please distance. And also, CDC has added, again, if you're asymptomatic and vaccinated, but you're a close contact, please test around 3 to 5 days after exposure. We do know that some persons who are vaccinated can develop COVID-19. So even if you're asymptomatic, be tested after your exposure. What are other exceptions to quarantine? Well, again, asymptomatic, we go back to if a person does not have a cough or a fever or a runny nose or other symptoms of COVID, again, headache, sore throat, muscle aches, joint pains, again, the vast array, nausea, vomiting, there's so many symptoms that can go along with COVID. But again, asymptomatic close contacts who have tested positive for COVID within the last 90 days or 3 months, and they, again, if they're asymptomatic, do not have to quarantine. In other words, if you're a case of COVID, if you've had COVID in 3 months, you don't have to home quarantine. And again, that is presuming that you don't have symptoms. And the reason for this being, and I know a lot of people want to talk about natural immunity, so I'm going to go ahead and quote some information that I have been reading about natural immunity. Natural immunity, we believe, will last at least 90 days, but could last as long as 7 or 8 months. The problem with natural immunity is that if you look at cases of COVID in a research setting, you can see that some persons who have had an asymptomatic or a mild case of COVID don't mount a very good immune response. So their natural immunity is not really going to be as robust as someone who had a very severe case of COVID, was potentially hospitalized and had, again, other factors. So their natural immunity to COVID may actually be better, but look at what they had to go through to get it. So I think this is what we have to remind people, that just because you've had COVID and you have some potential natural immunity, it's not going to be equivalent across the spectrum if you're asymptomatic versus mildly symptomatic versus severely symptomatic. So again, look at what you have to go through to have good natural immunity. You have to be very sick with COVID. So I think that's an important thing to remember. In addition, when we're talking about guidance today, and we're talking about what we really want to look at in terms of our school setting, we certainly, again, want persons to adhere to the school guidance in terms of kids being in classrooms universally masked, certainly distancing 3 feet or more, we recognize to the extent possible, but let's try to keep that distance. Let's try to keep the good hand hygiene. But we have made the decision, based upon extensive review of literature, to allow close contacts. Again, we're not talking about the exceptions. I already talked about the exceptions, but we have made the decision to allow that if children in the classroom setting are identified as close contacts by definition, then those close contacts, if they remain asymptomatic during the entire period of home quarantine, up to 7 full days, if these children are tested on day 5, 6, or 7 with either a PCR or an antigen, and again, they have to be tested not earlier than day 5 after the exposure. In other words, sometimes people want to say, I want to get an immediate test, and if it's negative, I want to return. No, it has to be 5, 6, or 7. And again, if the person is negative on any of those days, again, 5 days after exposure or later, then they can return to school on day 8 as long as they are asymptomatic. But keep in mind, as I talked about earlier, that the incubation period can be longer. So these kids that are able to test and return after 7 full days still need to wear their mask, maintain 6 feet of distancing, and continue to follow respiratory hygiene. The reason for that being, again, we want to do all we can to ensure that that last 5% or so risk of transmission is mitigated to the extent possible. We've really put in a couple of documents from the CDC, the information that they updated last week, and I like to say that they really rearranged their school guidance. There was not really any new information, but there was a rearrangement of the guidance, and part of that rearrangement is that they added a couple of algorithms, and we're putting these in the school toolkit because this first algorithm shows how we would identify a contact in the classroom in the setting of universal masking and 3 feet or more of distancing. And then the second algorithm is an algorithm that really applies to the setting where it's not in the classroom, and also when we're looking at students, where we're looking at staff and teachers. And again, keep in mind that the consistent masking and 3 feet or more of distance in order to not be identified as a close contact relates to students in the classroom. So we're adding these two algorithms to the toolkit.
Thank you all so much. That was very informative, and we appreciate both you, Dr. Landers, and Dr. Stubblebill for taking that. I'd like for us to answer some questions that were submitted to us by school nurses who are dealing with a lot of different scenarios. So the first question I have is a student has symptoms. They have a rapid test done which is positive, but the PCR test is negative. So which do we take as school nurses?
Dr. Stubblebill, would you like to take that question?
Absolutely. So a positive test is very, very likely to be a positive test, regardless of how it's taken. In a patient, especially a symptomatic or exposed patient, any positive test should be referred to as a positive test, and a negative test would not overrule a positive test. It is much more likely for a test to be falsely negative than it is for a test to be falsely positive. And remember, like Dr. Lander said, if there's any difference in the way that the test was collected, it could potentially invalidate the test because not enough of the antigen would make it onto the testing material, and then it could be falsely negative. So I would consider a positive test, regardless of the way it was collected or what type of test it is, especially in a contact or a symptomatic patient.
And I think just to follow up on that, again, as our ID&O department has discussed and our state epidemiologist, when we're talking about situations of this nature, we've got high community transmission and we also have a person with symptoms. So again, the pretest probability obviously is there, and so again, a symptomatic person in a high level of community transmission, we have to err on the side of the test positivity being, again, a true positive in this particular context. So I believe that, again, this is where there has been confusion, and as we pointed out, not only in terms of timing of testing or technique here, but we have a symptomatic person who has a positive test, and that test needs to be considered positive given the transmission that we have in the community right now, and again, the overall clinical picture. So.
And I have a question, if I may ask, because I've heard that a lot from school nurses also. If a rapid test comes back positive, do you need a PCR test to confirm that?
Well, I think in the practice setting, I'd also like for Dr. Stubblefield to weigh in on this, and I think in the practice setting, what we have looked at, again, is if you have a kid who comes in and they're positive and they've got symptoms and they're positive, then they're positive. So we don't need a PCR to confirm that, a positive is a positive. I think if we look at, again, some settings that we've had recently, if we had situations where a child had symptoms that were somewhat vague, and let's say we had like a negative antigen on that child, but we had kind of a vague overall history there, then we really need to do a PCR on that child again. We go back to the symptoms so that, that would be where a physician would need to make a clinical decision. But, if we had like a negative antigen, then we really want to confirm with a PCR. But if we have a positive antigen, there's no need to do a PCR to follow up on that. Dr. Stubblefield, would you like to add anything else to that?
Nothing to add. That's perfect. So in the clinical setting, I think everyone understands and knows that certain levels, a PCR test is the standard test. It's the one where all the other ones are measured against. And different types of tests have different levels of correlation with the PCR test, some being relatively poorly correlated and some being more highly correlated. Keeping in mind that a false negative test is more likely than a false positive, then a suspicious negative test should always be confirmed with a negative PCR test, whereas a positive test of any type would be considered to be a case of COVID.
Thank you both very much. There's a lot of confusion about allowing household contacts, so they've been exposed to somebody in the home, to come to school because schools are not quarantining children. So that was one question that the school guidance really didn't go into household contacts. So do you all want to comment on that?
Sure, I'll take that one, and then Dr. Stubblefield, again, bringing his experience more recently in the practice setting to follow up. It is so important, as we talked about, when we have a case of COVID, that the persons who are around the case, who are identified as contacts, and again, in the home setting, your children, your family members, very unlikely to be wearing a mask around the house, social distancing and respiratory hygiene. That's just not going to happen for the most part in your routine home setting. So let's say we have a case in the home, a parent or another child in the home, then the other children in that home, the other parent in that home, again, are contacts to that case, And again, we don't have that mitigation like we have in school, where they're in the classroom fully masked, distance. I mean, we don't have that mitigation being practiced in that home setting. So we've just increased the level of exposure there. So these contacts to cases in the home represent a significant risk in terms of bringing COVID to school. And if we look at what happened last year, we saw that kids brought COVID to school more than kids contracted COVID at school because they were in a controlled environment in school. And obviously there was masking and distancing. But again, these kids have had a high exposure, or these household contacts have had a high exposure. And so they need to stay at home. They need to follow the home quarantine. And again, as we go back to, contact has to be broken in that home, and that may or may not be able to be done. I mean, some people don't have an additional caregiver that could take care of the child. They don't have the space in their home. They don't have an upstairs, downstairs, or maybe a completed basement room. So that contact may not be able to be broken in that home. So we're really setting up the other people for more and more and more exposure every day that contact goes to school, comes back home, goes to school, comes back home. They're, again, putting the other children at risk. So I think it's very important. And again, we go back to contact being broken. It may not happen. And if it can't happen, then you can't start home quarantine until such time as the original case has completed isolation. Now, I'm a big proponent of, testing people, and certainly testing people in that particular setting in a home. What I have seen, again, because I've had a caseload of patients myself in COVID, is when I've had a case in a home, I've usually had 2 or 3 more cases in that home because, again, it's just impractical to think that contact's going to be broken a lot of times. Dr. Stubblefield, would you like to follow up on that?
That was perfect. The only thing I would say is, as a parent myself and parents out there that may be watching this, that's why it's so important to notify the school officials or the school nurse that your child did test positive, so that we can go through with these mitigation strategies to keep other kids from being sick and to keep our schools open, to keep the classrooms going, to keep adults in the classroom from getting sick. I think that's very important.
And I mean, really, that's our goal at the Alabama Department of Public Health, is to keep kids in school. And that's why we have recommendations to mitigate COVID. We do have another question about when a student loses sense of taste and smell, which is sort of an unusual thing. Is that usually COVID?
Well, Carolyn, we've talked about this a lot, and again with our IDNO nurses and our IDNO team, because this is a very unusual symptom in children. And again, having been a pediatrician for many, many years myself, I can say that in various instances of respiratory illnesses, this is really not something that you see. Again, in the pediatric setting, certainly in the older kids and adolescents, they are able to identify and report this symptom. But I'll just give a clinical scenario, and I definitely have sought Dr. Stubblefield's counsel on this because of his recent clinical experience. I had a child about a year ago. Again, we were testing people that didn't have, obviously, a primary care provider. This particular child did not have a primary care provider. And this child, again, being about 11 years of age, had no symptoms that the child reported to the mother, except starting to complain that everything that this person ate tasted like liver. And there probably aren't too many 11-year-olds that want to eat liver, so it must have been a very bad taste that this child was reporting. So the mother actually had the child tested, and the child did test positive for COVID. But if I had a child come in to me and tell me that they said everything tasted like liver, or tasted funny, or tasted odd. We talk about loss of taste or smell, but it can also be like an aberration here, where everything tastes really strange or really funny, or all of a sudden I can't smell my food. So again, there are these kinds of aberrations that you normally just don't see in pediatrics. But again, loss of taste or smell, and I qualify that by saying in a child that can really tell you that they've lost taste or smell or have some kind of aberration, then I think that we have to take that as clinical COVID. You know, one other thing to remember about loss of taste or smell is if we think about the olfactory nerve, which is really responsible for smell, I mean, we really have a cranial nerve that is literally exposed, you know, in the nose. So it makes sense if we have persons breathing in respiratory droplets and those droplets infect, I mean, that virus is really going right to the nerve. It's really having direct impact on the nerve. So in looking at some literature in pediatrics, I think it's not a common thing, but in one study I read it was probably about 10 or 15%, which seemed a little higher than I would have expected. But I consider that clinical COVID, again, in a reliable historian, because I'm not sure that a 5 or 6-year-old could really tell me much about taste or smell. Dr. Stubblefield, again, please bring your more recent clinical experience to this discussion.
I agree. Loss of taste or smell has not been something I have seen in my 14 years of practice as a consistent symptom associated with any other infection. And so this loss of taste or smell, especially in the setting of high community transmission, should be assumed to be COVID regardless of test results, in our opinion.
Thank you. School nurses have been caught in a situation sometimes when doctors' offices will send notes for students to return. So we have several questions about why some physicians are not following recommendations from public health or the CDC. Why are close contacts of a positive case and the doctors will write them an excuse to go back to school? So there have been a lot of scenarios that have been expressed by the school nurses to sort of get an idea why there's so many different kinds of practices around COVID and how people are following different recommendations. So do you all want to comment on that?
I'd be happy to start.
Sure.
And,
absolutely.
So I think it's important to remember that COVID testing is being done in many situations by many different types of providers, and so that's why it's so important that any provider that is testing for coronavirus disease in a clinical setting be familiar with the guidelines so that they can then give appropriate and tested counsel to their patients and their families about when they should and should not return to school. And if we do our job and not deviate from those practices that we've outlined, then we're going to keep kids in school, we're going to keep our kids open, and we're going to reduce community transmission. So making sure that you're familiar with the guidelines, making sure that you're following what we've outlined is very important. And to again, to realize that these settings are done in multiple different settings, and so it's not a failure of any person. It's just that we all need to be as familiar with this as possible. The other thing that I wanted to mention was specifically one of the questions mentioned an antibody test, and antibody tests can show that you have developed antibodies to a particular infection. But with COVID, we don't know what the antibody test means. So a positive antibody test means that you've been exposed, but it doesn't say how long the exposure has been, whether or not you're protected from the disease. And so you can't use that as clinical guidance for returning to school, treating an infection, quarantining, anything like that, unless, of course, it was within that 90-day period that Dr. Landers talked about before. So it's the time, not necessarily the presence of antibodies on a test. Those data will have to be vetted over probably many years and many more studies before we're able to, even at some point, use antibody testing. And I can tell you from some other diseases that antibody testing is also very difficult when it comes to knowing whether a person is actually immune to a disease or not.
Mm-hmm. And just to follow up on that, again, last year our ID&O team worked very diligently with us in trying to help convey the correct information related to isolation and quarantine. And everything that we do in the Alabama Department of Public Health and every guideline that we promulgate out is related to literature and is related to science and is related to guidance from expert bodies. Certainly the CDC obviously provides a lot of guidance, but we have a number of other specialty organizations that take care of groups. I mean, pediatricians, for example, OBGYNs, for example, emergency medicine, internal medicine. If you look at all of these societies, you will see that each society has guidelines, but again, Infectious Disease Society of America, these guidelines are all based upon the information that we know related to mitigation. So you're not going to see that there is a deviation, if you will, from the standard expectations that we all have as physicians to keep patients safe. Another factor that I would like to mention, and I know Dr. Stubblefield ran into that in his most recent practice, is that sometimes caregivers, parents, when they are providing information to the healthcare provider, they may not have all that information, or they may have misunderstood the information they were given about their child being a true contact. And I had that happen in a number of instances where persons were being tested through urgent cares, where, again, the urgent care center's doing a very good job in testing a lot of people, but when the person came to be tested, they didn't have the information, or they didn't provide the information, I was a contact. It was rather, okay, I'm being tested because of being in school, I'm being tested, I need a negative test. So again, in the rapid pace of trying to test everyone and get everyone taken care of and have everyone drive through the line, persons would be just given a copy of their negative test, return to school, negative test, return to school. And in speaking to many of these providers, the same theme over and over. I didn't know they were contact to a case. I thought they were testing because all the people in the athletic team were asked to be tested, or all the people in show choir were asked to be tested. I didn't know. I didn't know. If I had known they were a contact, I would have advised them to home quarantine, regardless of the result of the test, because again, people were going and getting a test and coming back to school. So I think there was a lack of communication there, and again, parents and caregivers wanting to do their very best for their children, and the entity that was testing wanting to get that test done, provide that test, and be able to move on to test the other people that were there, but really a lack of communication there. So we did a lot of communication with the entities that were testing, and I think the problem did improve. But again, there are times that people just don't have all the information. And I think just to follow up on another point about ensuring that everyone is consistent, is that the one thing that's been constant in COVID for me has been change. And so when there is a change in a guideline, that's part of the communication that we have through the Medical Association of the State of Alabama, the American Academy of Pediatrics State Chapter, our other organizations, and using our Health Alert Network, our HON, to advise physicians of this is a change, or this is something new, and this is a guideline, so that we can keep our healthcare providers up to date on this. Because one other thing we have to remember is, while we've been immersed in COVID, and I like to tell people I got repurposed out of tuberculosis to COVID, the reality of it is that physicians, healthcare providers, and urgent cares, they're treating a broad range of diseases every day, and it's not just COVID. So again, keeping abreast of what's going on in the world of COVID literature is an absolute challenge. And again, we try to address that through our specialty societies as well as through our Health Alert Network. And I really can't thank our IDNO team enough for the diligence that they have put into this. Thank you.
Thank you.
And I think that's also why it's so important that we've tried to take what's very complex information and make it something that's approachable by the public and by those giving care. And so hopefully you find this information helpful and clear, so that you can make good decisions about keeping our kids healthy and in school.
Well, speaking of changes and the fact that we are in an ever-changing environment with COVID, we have a question on the new 7-day test to stay modified quarantine. And the question is, does this modified quarantine apply to close contacts outside of school exposures? So
Okay.
do you want to take that?
Yeah, I can take that one. And again, as I addressed just briefly in my introduction to this, and just to clarify, if we look at what CDC allows, again, 14 days will always remain preferable, 10 days is allowed, and 7 days is allowed with, again, still keeping mitigation in place in terms of masking, social distancing, respiratory hygiene. So, you know, in the situation where we all could do 14 days would be optimal. And I quote our state epidemiologist on that. I think she uses the term optimal all the time. But we are in a situation where we have to make some modifications in terms of people's economic survival, in terms of keeping kids in the classroom, and I think you've heard us say that over and over because we're really talking about schools today, but you know, economic survival for the parents, keeping those kids in the classroom so that they can learn. So each state can look at the guidelines from CDC and make decisions based upon what is happening in that state. And of course in Alabama, we've had a really rough ride with COVID. We've had very high transmission many times in our experience throughout this pandemic. So, of course, the Alabama Department of Public Health did make a decision, I believe it was actually about a year ago, to go to the 10-day quarantine, but we did not opt for the 7 at that time. With further review, our determination in talking with our ID&O team and also our Chief Medical Officer, Dr. Mary McIntyre, has been that with the exception of allowing this in the school setting, we do not feel that adopting the 7-day and test is appropriate for the broad population in Alabama, but rather our implementing this in a specific group that hopefully has a controlled environment by using universal masking in the schools, good social distancing in the schools, the 3 feet or more, good respiratory hygiene. So really implementing this primarily in a controlled and closed environment, if you will, because we have those kids, again, for that 8 or so hours in a day. So that's why we have not implemented the 7-day broadly in Alabama, given, you know, as I was talking about, high community transmission. So it's really a decision based upon multiple parameters in our state and in conversation with our expert team. Wes, do you have anything to add to that?
I don't. I think that's very important to remember that each state is allowed the leeway to decide what's best for its own state. And at this point, this is where we are.
And I do want to mention that we do cover this in our update to our back-to-school guidance, which will be released early next week. So I just want to mention that all of the changes that we discussed today are reflected in an updated version of the back-to-school guidance, which will be posted on the Alabama Public Health website. I'm just going to ask, we do have a couple of more questions if y'all are willing to hang around for another couple of minutes. So one school nurse is incredibly frustrated that parents who have tested positive for COVID are still bringing their children to school. And we already talked about the fact that their children would be considered a close contact. What advice would you give school nurses that are facing these parents? So that's sort of that's a tough one. Yeah, that's a very tough question.
I'm going to let my younger colleagues start off on that
one. Earlier, we were speaking to the importance that that we all have, that we as citizens of Alabama, as parents, that we are open in communicating with our school officials, our school nurses, our providers, and how important that communication is. If we don't communicate with each other well, we're not going to succeed in this. And so communication is vital. And so I think it's very important to encourage, have those relationships, encourage that communication, get that word out in the school system that you really want for parents to come to the school with that, or call the school with that information, so that we can make the best decisions we can about our kids. And again, keeping the kids in school. We want the kids to go to school. We want kids to be protected. And so I think lines of communication need to be open. They need to be equitable. They need to reflect what's going on at home, so that because otherwise we can't make good decisions in the school setting, and we can't ensure that our kids are going to stay healthy.
Right. And just to follow up from the public health standpoint, and I think that's where we've had these situations to occur before. And again, many times it's just a gap in knowledge. It's just that the parent does not realize that that's the situation, that by their having COVID and continuing to bring their child to school, that they are really continuing to promote the spread of COVID, and they wouldn't want that to happen if they were in an opposite setting. So the school nurses, let me just say, I know that they're going to be part of the audience listening to this, have really been my heroes in the last over, let's see, a year. It seems like it's been forever, in working so diligently to protect not only the students, but also the staff members and the teachers. And again, these professionals out there, they know these guidelines, they understand these guidelines, and they absolutely have done a wonderful job. But we know that this is a sensitive topic. And so I have told the school nurses, and again, through our Department of Education contacts, that if they continue to have a situation of this nature, and a parent continues to bring a child to school that is a contact, in other words, that child is in that home with that parent or caregiver with COVID, and they keep coming to school, then really that school nurse needs to let us know. They need to let us know. Again, I tell people, start at your district level and talk to your ID&O nurse, because at the district level, the infectious disease and outbreak nurse many times can speak to the parent and help them to understand where we are as the Alabama Department of Public Health in trying to protect everyone against disease transmission. So many times, and I've had that resolved in some of my own counties by my own ID&O nurse, but if they can't resolve it, and again, I've told the nurses, if you can't resolve that issue at the district level, then contact me. And now that I have Dr. Stubblefield, I'll say contact him. So, but again, contact us as pediatricians, and we will work with our ID&O team and our other resources in the department to, again, help parents to follow these guidelines, because we feel like most of the time, the experiences I've had, it has really just been a misunderstanding on the part of the parent, and they're wanting to keep their kids in school too. But again, we have to do this with respect for the other students and the safety of other students in mind.
Thank you. My last question has to do with the mask, having masks in schools. And from what I heard from Dr. Mackey and Jennifer Ventris, the school director of school nurses statewide, is about 90% of our schools did have some kind of mask mandate that they did a local decision makers. What this nurse wants to know is, we are now seeing some schools, because of the positivity rates going down and the hospitalizations going down, want to remove the mask mandates. And so when is the right time to do that? How should school nurses and other decision makers look at the mask, and when is it time to remove the mask or keep the mask on?
Sure. And again, I'd like to start out and then also have Dr. Stubblefield to follow up. A couple of things about masks. As a pediatrician myself, again, of many years' experience, you know, I really unequivocally want to state that masks work and masks are not harmful. Again, children will not be harmed by wearing a mask, and they do work. And when we think about trying to prevent COVID in children, this is one of the important layers of mitigation. Mitigation is layered. We talk about not only masking, social distancing, we talk about the respiratory hygiene. Also, some factors we don't talk about routinely, but we do implement, are like environmental cleaning. And again, speaking to the issue of people being vaccinated. So again, there are several layers there, and you know, I like to call it like Swiss cheese. If you put 3 pieces together, you're unlikely to get the mustard from one side of the bread to the other. So masks work, and they're part of the mitigation. And if we don't protect children from COVID, and again, if we continue to have the spread of COVID, think about this harmless measure that we're asking people to do, to wear a mask, that this the damage that can be done is not about wearing the mask. It's about losing your family member to COVID, losing your grandmother, your grandfather, your parent to COVID, you know, not being able to come to school. Some kids rely on school for breakfast and lunch. I mean, again, we want to keep kids in school. So again, masks are helpful and they are not harmful. Now, following up in when do we relax mitigation? And again, having dealt with this for a long time, you know, I go back to looking at what is going on in the community. And it's very tempting. We just put out a news release today actually talking about some of the community transmission. It's very tempting to say, well, percent positivity is going down, numbers of cases are going down. Well, I really just don't know about, you know, there's fewer people testing positive. You know, let's just take this off and see what happens. With the virus we have this year, which is not last year's COVID, I want to remind people, with the more transmissible SARS-CoV-2 that we have, the Delta variant, we know we see more cases. And even right now, with the numbers of cases going down in the state of Alabama, Dr. Stubblefield and I both look at data every day related to pediatric cases, and we're still seeing our pediatric cases a little higher than we'd like for them to be in the hospital. About 25% of our cases of COVID in Alabama right now, as of today, are in the 0 to 17 age group. We probably have somewhere in the range of about, if you average it over 7 days, probably about 40 kids in the hospital with COVID. Now that's gone down, but that's still kids in the hospital. And then we also have the situation of kids on ventilators. And again, we've had anywhere between 6 and 10 kids on ventilators in Alabama in any, you know, given day. I think we were down to about 6 yesterday, and that was really good. And I felt encouraged by that. But we are not there until we get well into the single digits. You know, I certainly like to see the low community transmission, but we are nowhere near being able to relax. In fact, let's take it another way. By schools putting these measures into place and protecting the students and keeping the kids in classroom, you know, that has contributed to our getting COVID down. But again, keep in mind that, you know, kids go other places besides school. And when we think of our community transmission being what it is, we're just not ready. Now, I know a lot of people say, well, what number is that going to be? Again, you know, we give data, we give information for persons to make decisions based upon that information. I mean, I would certainly like to see transmission rates and numbers of cases much, much lower than they are now. So again, going from high to substantial to moderate to low is not going to happen overnight. Dr. Stubblefield, what did you have to add to that?
I think that everything you said was great. One thing I keep coming back to is making sure that we're using data to drive our decisions, as you mentioned before. So trying to come up with a measure for what seems to be appropriate might not be the best strategy. So for example, the number of children who are currently out in terms of either quarantine or isolation, that is not a number that we should be using. What the number we should be using is community transmission. So if we were to see low and sustained levels of community transmission, I think it would be a conversation that we could have again at some point in the future. But as Dr. Lander said, right now we're not at that point, and that decision needs to be made in the future, not when we're just now starting to see some relaxation of the numbers. But we should be vigilant about our mitigation strategies.
Thank you all so much. We so appreciate Dr. Stubblefield, and welcome to ADPH and Dr. Landers being here today to join us. And I just want to thank all of the administrators, superintendents, principals, school nurses, school boards that have worked so hard this year during a very challenging time with the Delta variant, which, as Dr. Landers mentioned, is much more transmissible. And we certainly appreciate you all joining us today. This is an update based on our back to school update that's being published on September 23rd, 2021. This is a document that we will be changing with changes in information from the CDC and from the FDA and from the scientists. So this is a document that can change and may change, but we do appreciate you all joining us today, and we will certainly keep you updated on any changes that we have in the future. Please feel free to reach out to your local IDNO nurses or to anybody at Public Health with any questions you have. And thank you again for joining us. Take care.